what I plan to talk about today is start with thinking about the role of mental health services for children with autism. It's often an area that we think of more of as a secondary service system for this population, and to think about the important role of them. Then discuss the process that I use to develop the AIM High intervention. I'll give you a bit of an overview of the AIM High protocol, just to give you an example of how we are translating what we know that is helpful for children with autism and translating it into something in a package that can be used by mental health providers. And then I'll give you a little bit of an update on some of the current AIM High research that's going on, and hopefully future research. So just to give you a sense of where I'm coming from. So I'm a child psychologist. I primarily conduct research, and I conduct translational research. And translational research means it covers a lot of different areas. We often talk about translating, animal science to humans, to basic science, to clinical intervention research. So I'm on this far right side conducting research in the community. So I have a lab, but it's really just a couple of offices. My laboratory is in community service systems. So that's really where the context of my research. And I really blend that research, community-based research, and my own clinical background. So there's been discussions today about the different silos that are in play when we're talking about special education and services. We're talking about children with autism or adults with autism. There may be a number of different service systems that are involved in caring for these children at one time or another, and sometimes concurrently, actually often concurrently. The mental health system has, until recently, received less attention than early intervention or education, but there's really kind of the growing understanding about the important role of community mental health or school-based mental health for children with ASD, particularly those who are school-age children, right? So when I'm talking about the AIM High intervention, we're really talking about, this was geared towards children who are around ages 5 to 13. There are certainly adolescents, for sure, that are involved in this system as well. But our intervention is for that group of children. And so when I say mental health system, I probably inaccurately imply that there's one system. There isn't one mental health system. There's specialty mental health, there is school-based mental health, there's educationally related mental health services that are all involved in caring for children's social-emotional needs, and psychiatric needs, depending on what context you're working in. But there's growing awareness of the important role in caring for both the behavioral challenges that are associated with symptoms of autism spectrum disorder, as well as the high rates of comorbid psychiatric conditions. So about 70% of children with autism meet criteria for another mental health disorder. So we would expect that mental health providers would be caring for our children. So some of the most common mental health conditions that are seen in children with autism are anxiety, disruptive behavior disorders, ADHD, and so forth. So those are common. So this is really the area that I conduct a lot of my research is in mental health settings. So in my earlier research, I came from, my background is in early intervention. And when I was doing some of my internship training, I wanted a general child clinical training. And so went to publicly funded mental health settings and was surprised to see so many children with autism being served in this context. And so that's really what piqued my clinical experience, is what piqued my interest in this area of research. So some of my early work was really about understanding who are these children who have autism, who are served in mental health setting? What are their clinical needs? What's the training and the needs and the capacities of the providers who serve them? And so we did a number of different kind of methods to kind of understand this context of this research. And not surprisingly, what we found, and this is not specific to autism, but I was studying autism, is that children present to mental health services for challenging behaviors. That's the case for children without autism, and it's the case for them as well. So regardless of what is their profile of maybe comorbid mental health systems or symptoms, that's really what is getting them to mental health services. And often the co-occurring mental health symptoms are contributing to the challenging behavior, which is what they're presenting with to mental health services. So most mental health services are provided either in outpatient clinics, maybe with some community-based components, depending on which county folks are working in, or in the schools, school-based clinics, or school-based services that they look very different depending on the district or even the school. But really, the most common pathway to mental health services are challenging behaviors. What I should say about mental health services, and there may be exceptions to this, but most of the time, even though we often refer to them as specialty mental health services, that they don't specialize in one specific disorder. So in a general child outpatient clinic, whoever walks in the door is who's being served, right? They meet medical necessity for mental health services, or they have social emotional goals on their IEPs, and they're receiving educationally related mental health services. But they often don't typically specialize in any particular disorder, and especially in autism or other neurodevelopmental disorders. So in my current study that we're actually wrapping up, we have about 202 children with autism that were recruited from mental health programs in both San Diego and LA County. And when they came into the study, we conducted a structured diagnostic assessment of their psychiatric assessment. It's a parent interview, structured parent interview. And not surprising, almost all of them met criteria for another mental health condition besides autism. Now, we would expect that to be the case because they're receiving mental health services. But there are some programs that didn't require them to have another diagnosis, but there's very, again, not surprisingly, children with ASD who are served in mental health services had high rates of challenging behaviors. The most prevalent mental health condition was ADHD. I don't know if you can see this, but 80% of the children who were in our study, they met criteria for ADHD. And then over 50% met criteria for oppositional defiant disorder, disruptive behavior disorder, anxiety disorder, and mood disorder. And most of these children met criteria for more than one, right? So I think this just starts to paint the picture of who are the children that have autism and who are also receiving mental health care. And in some ways, those of you who are working in these settings, this really indicates somewhat the complexity of the symptoms that these children are presenting with, that in addition to autism, that they have one or more, most likely more, mental health disorders that they meet criteria for. I just want to point out again that we know from the research that challenging behaviors are often I should say that these psychiatric conditions often underlie these challenging behaviors. So even if we think of anxiety or depression as internalizing disorders in which children might typically withdraw, they still contribute to challenging behaviors. And so that's really what we found very significantly in our early needs assessment work. So we, in our needs assessment, we looked at surveys of providers and focus groups of providers and interviews with parents, really to get a sense of what are the clinical needs of these children and what are the training needs of the providers who are serving them. So what we found, this is a more succinct slide that really took over a year to gather all this information, but these are kind of the bullets, is that we were able to look at a study of usual care psychotherapy that was not necessarily focused on autism, but that involved collecting over 3,000 video recordings of psychotherapy sessions. This is all in San Diego County. And we found that we coded these videos for use of evidence-based strategy that are common in children with ASD. So teaching strategies, using role play and modeling, behavioral rehearsal, reinforcement, and so forth. And that we really saw low intensity of evidence-based strategies being used. And that wasn't just for children with autism, but also for children without autism. But what was unique for this population is that the therapists were really frustrated, that they felt that they did not have, we kept hearing the words, we don't have the tools to work with this population. We're expected to conduct psychotherapy or in the schools counseling sessions with these children, and what I do with other children doesn't work for this population. And so they were really, really frustrated. I don't write this, but I would go to say that they felt desperate for something for this population. And we had therapists tell us how many kids were on their caseload, and of those, how many had a diagnosis of autism. And it was around 20% of caseloads of mental health providers involved either children that had already been diagnosed with autism or who they were pretty sure had autism. So they're seeing lots of children with autism. And so we said, okay, well, let's take an intervention that we can use and train mental health providers to use it. And so then we started working with my community partners on, okay, well, what are we going to teach people to do? And there wasn't really anything to teach people to use in this setting. There's educational packages of strategies, or there's strategies that are for more early interventions, but there was nothing I could take off the shelf and say, okay, let's use that. So then that's what led to the development of AIM High. So I really didn't intend to go down this road. I just was interested in how do we train people to use evidence-based practices. But since there wasn't something implementable, we really embarked on, let's develop something that could be used. Despite not having a package to take off the shelf, what we do know is that there were lots of common elements of behavioral and cognitive behavioral packages for children with autism, that they really shared some common elements that we thought, okay, well, that gives us a foundation. We're not really creating something completely new. We just need to package these strategies that are common so it can be used in this setting. So it wasn't that there was no evidence base. It just wasn't packaged in a way that we could hand to a therapist. So really this research was really in response to a research practice gap in mental health services for children with autism. So we have routine mental health services, what are just community school-based services, and then these evidence-based strategies, mostly cognitive behavioral strategies that have a lot of research support, but then how do we link these two? And so that's really what contributed to the development of AIM High. So we've been at this for a while, and I won't go in absolute detail into all this, but as I mentioned, I didn't want to just develop something and without really systematically attending to ensure that it would fit with the end users of the intervention. So I viewed the end users of Aim High as therapists, parents, and the children. And so that's why we really spent the time to do our needs assessment, which I've talked about. And then I spent about a year with a research community partnered process where we interpreted the results of our needs assessment. Okay, well, what are we hearing that we need? And then looking at that, we were able to look to the research to say, okay, what do we know works that's going to meet the needs of these children, their families, and the providers who are serving them? So we met over lunches and breakfasts. The food was helpful in this process. And worked on many drafts of materials and got feedback from folks. And sometimes when we're working on materials, therapists and parents didn't necessarily agree on what was most useful. So we really got a lot of feedback, and then conducted a pilot study using the original Aim High manual. And I'll talk about that in a minute, but I think that the process of developing the protocol was important in that we were based in the literature, we're based in the research, but with this intention, how is this going to fit within a service system? So at that time, we were focused mostly on county-funded, Medi-Cal-funded services and educationally related mental health services. And so what we tried to do is make sure that everything that was part of an intervention didn't duplicate what already was required for funding, because that's very stressful and annoying to people, is when you're asked to do the same thing over and over. So really attended to, well, how could this piece contribute or help me do my required treatment plan that I need to do in 30 days, for example, for Medi-Cal funded. So that was our process. I was still revising materials this morning, and this is many years ago. So it's just kind of an iterative process. We get a lot of feedback. So what is Aim High? So I would love to claim that I created something new. I really didn't create something new. I packaged the good work of other folks just to fit within our mental health service settings. So I call it a package of evidence-based, parent-mediated, and child-focused strategies that's designed to reduce challenging behaviors in children with autism ages 5 to 13. And I often share with people, our partnership group, we thought about, very briefly, maybe about 10 seconds, we considered, well, maybe we need a module for autism plus ADHD, and then one for autism plus anxiety, and then autism plus depression. It just makes no sense because it's not feasible to learn, and the children are presented with challenging behaviors. So that's what was going to be addressed. So that's why we really threw out that notion of starting with what was the diagnosis and really going to what's the presenting problems. And so we take a function-based approach to address the challenging behaviors, and then we address the other and the associated psychiatric symptoms within this function-based context. So it's not that we're ignoring the anxiety or ignoring the ADHD. It's very much a part of what we're doing, and I'll illustrate that in a bit, but our starting point is the challenging behaviors. Does that make sense? Okay. And again, all of the individual components of the intervention were already well established. And so as I already mentioned, that it was developed in collaboration based on our needs assessment. We also, when we heard that the therapists felt that they didn't have a lot of training in autism or behavioral interventions, so our materials are geared for folks that are not autism experts and who are not necessarily behavioral experts. And I'm still working on taking out some behavioral language because it's in some ways unnecessary, and can turn people off. So we're just really trying to say what we mean. in our materials. So that's aim high. So I know this is a lot to read, but I just wanted to share with you what the aim high intervention entails. So when we did our needs assessment, I really actually didn't think about this before doing the needs assessment. But what we heard over and over from therapists is we don't know how to do treatment planning for these children. We don't know what's a reasonable goal. They have so many needs, and I see them for an hour a week of psychotherapy. Where do I start? What do I do? So we heard this repeatedly. I need to be able to set reasonable goals, and I need to know how to track progress. So that's why the first part of the first phase of aim high treatment is treatment planning. Now, in reality, I view this as intervention. I view conducting a functional assessment, which is really where we start. I view that as part of the intervention, and we work with parents on that, so it becomes intervention for parents at that point. But the therapists really felt they needed to be grounded in the treatment planning. So that's the most structured part of the aim high intervention, is treatment planning. And what that involves is integrating the information that a therapist has about the child, starting to view the child and the child's behavior from an autism lens. So we often talk about that in our training is, okay, let's put on our autism lens and think about behaviors beyond being oppositional. Because I think that, mental health providers who see a lot of kids with oppositional behaviors tend to ascribe the same meaning behind their behaviors that may be a little bit different when we're talking about kids with autism. So this integrating assessment information is really kind of starting to understand behaviors by understanding their autism symptoms or their other mental health symptoms, or I should say. Then working with parents to track children's behaviors and understand the patterns of the behavior. This is nothing new, I'm assuming, to folks in this room, but it is something that's new in community mental health often. And then developing a behavior plan, integrating into the mental health treatment plan, and then the active treatment involves active teaching of parent and child skills. And so that's really the focus, is very active skill building. And then, of course, evaluating our progress. We also talk about, in our needs assessment, therapists kept telling us, so therapists used the same words over and over for us, so it really helped us to focus on what do we need to do. So in addition to saying we need help with treatment planning, they said we need help adapting psychotherapy because I have a hard time engaging a child with autism and their parents, and I don't know how to run my sessions so that I can even teach a skill. And so, again, what works for other kids doesn't work. That was this perception. So we kept hearing about we need adaptations. We need adaptations. So as part of the protocol, we have these within session elements. So this is what we would expect a therapist to be doing across these steps. But it's really about using structuring a session for skill building and things that everybody probably in this room wouldn't even necessarily think twice about, but using schedules, using visuals, using materials with parents to help make abstract concepts concrete. And a lot of psychotherapy is pretty much all abstract concepts. If we're talking about emotions and emotion regulation, it's all very abstract. And it also occurs in the context of an ongoing social interaction that can be challenging for anybody. And so we're really focused on the structuring sessions. And then we talk about engaging parents and children. And so to engage children, we use pivotal response training strategies, really, child choice, following a child's leads. So we use those type of strategies, really kind of harnessing the power of a child's special interest to engage them and motivate them to practice their skills in session. And then with parents, we really use a collaborative parent training model and active involvement. So parents are we really try to set the stage that parents are active partners in this treatment. But we really individualize what it looks like. Sometimes in the schools that can be challenging. So, and different districts have different approaches to how much they involve parents in their child's counseling sessions, for example. But one of the first videos I saw of this was a social worker, I believe, who's working in a school-based program. And it's during the day, and parents are working during the day, right? So I have a video of her doing the kind of parent training process and being engaged in the session by being on speakerphone. So there's this big empty classroom, child and the therapist are sitting at the desks, and there's a speakerphone, and mom's on speakerphone. And so we're really flexible about what does this parent involvement look like? Because if we view the parent involvement is in that the parent just has to be there in every session, sometimes we get some pushback, and it may not be feasible for everyone. So we try to be really flexible and have therapists just be creative. And how are we going to involve a parent? And then really, working on partnering with them. And then we use active teaching strategies, and that I'll go through in a minute, but it really is about actively teaching something that involves modeling and behavioral rehearsal and feedback. And I'll give you some examples of that in a bit. So this is kind of the protocol. So I hope I'm okay, and I hope what you see here is that this is nothing new. This is a function-based approach to addressing challenging behaviors. So we didn't create this. This is just how we packaged it. What our training model involves is we do an introductory workshop. It was one day, now it will be 2 days. That's really priming for therapists, that gives the necessary background. But it's necessary, but it is certainly not sufficient. And then we're the real learning of how to develop AIM High. It comes with delivering AIM High with an actual client or student, depending on the context, while they attend a consultation series that's about 11 sessions. And so during this consultation series, it's actually pretty structured, where we walk the therapist through the protocol as they're really delivering it to their family. And so then we give feedback, and we have video review and so forth. That part is really the key part about learning AIM High. So I just wanted to give you an example of kind of how we present these protocol steps to therapists and how we integrate the mental health piece. When we train psychiatrists, they always ask me, well, what about the anxiety, or what about the ADHD? So we're addressing that. We're addressing that, just that we're starting with the challenging behavior. So I want to illustrate that too. So our approach to skill building is really about this function-based approach. So first, we understand a behavior. I think this might be a little bit different than in the syllabus, because I wanted bigger words on the screen. But so really understanding the behavior is a functional assessment. But it's not done by the therapists. It's really the therapist guiding the parent to collect information about a child's behavior. And that process in itself is parent training. Because often what we see is that when a parent takes kind of our behavior tracking form home, and when they start to use it, they start to have some aha moments before the therapist needs to say anything. And so that process in itself, it's not just about understanding. I mean, it is about the parent understanding the behavior, but it's not just for the purpose of a functional assessment. It really is to help a parent understand a child's behavior. And it's so helpful for a therapist or a school psychologist, whoever's doing the intervention, to not have to explain. It's better when a parent comes up with them on their own, right? Then it's a real deeper understanding. So that's why I say it's really not treatment planning, it's treatment. And then what we in our behavior plans, we include alternative skills for children and complementary parent skills or strategies that are going to help the child learn the skills that they need. And I should say that from an ABA framework, often we talk about replacement behaviors. And we really try to get away from that because, if you have an anxious child and the function of that child's behavior is to avoid a feared situation, it's actually inappropriate to just teach them to avoid that situation, right? So we don't want to just be teaching replacement behaviors. We want to teach broader coping and tolerance skills. So we include kind of sometimes some short-term skills, asking for a break and so forth, that's going to result in a quick reduction of challenging behaviors, but then really understand, well, which broader skill is missing here for this child? And those are the skills that often link to their other mental health conditions. And then we identify the complementary parent and child strategies. In the schools, when we're training therapists and school psychologists, we use the term caregiver broadly, and because sometimes school psychologists will say, oh, well, can I use these same kind of adult learning strategies that you're directing to parents? Can I use them to teach an aide or a teacher and so forth? Sure, that's the child's caregiver for a good part of their week. So sure, it's really based on adult learning. So the adult is the adult as long as they spend a lot of time with that child. And then we use these active teaching strategies to teach both the child and caregiver skills. So how is this a mental health intervention? So why isn't this just, positive behavioral support? And this is why in some ways we had to develop our own, is that when we're doing that functional assessment, when we're collecting information about the child's behavior, we are definitely considering the role of the child's mental health symptoms in their patterns and functions of behaviors. So if you have an anxious child, it's really often the case that the function of that challenging behavior is to avoid something, right? That's very helpful information if we know a child is really anxious. So that's first what we think about that. It helps us give a clue as to what are the functions of the behavior, what's underlying the behavior. Then when we develop our behavior plan, I already mentioned this, that we don't stop at replacement skills, right? And in fact, sometimes we don't put replacement skills on the behavior plan because we don't think they're appropriate. And I think that the anxiety and the avoidance one really is a good example there. We don't want to teach anxious kids to avoid things. So even if they do it in a socially appropriate way, we really don't want it in the long term. So that's where on our behavior plan we have these general coping and tolerance skills. So in anxiety treatment, a major focus of anxiety treatment is to help children and adults to tolerate anxiety-provoking situations without leaving. So that tolerance is really important. We use exposure to do that and so forth. And so the other mental health problems really drive the skills that are put on the behavior plan. Also, I should say, on our behavior plan, we include, just like any other ABA behavior plan, we would include antecedent strategies and consequence-based strategies. But many of the antecedent strategies that we use for children with autism or other disabilities generally are also similar to what you would do for a child with ADHD or a child with other mental health conditions. And so often those are incorporated or help with those other conditions like ADHD. So for those children who have ADHD, which is many of them, when we're asking them to do something that requires sustained attention, like their homework, which is often, very often, the context of the challenging behaviors, we talk about an antecedent strategy of removing distraction. That's what folks would use generally for ADHD if children didn't have autism. We also do make a point that when we're thinking about what might be reinforcing for a child, so when we're thinking about, okay, well, what reinforcement should we be using when we're helping a child learn a new skill? Is it direct reinforcement? Is it it's special interest time? We have to consider the other mental health symptoms. So, for example, social praise is used a lot, and that's great unless that child has social phobia, then that may not actually be reinforcing. So that's just another example of how we would consider those other mental health conditions. And then when we teach the child their skills, we often are integrating intervention strategies that are for the other mental health conditions, which is really cognitive behavioral therapy. So that involves cognitive restructuring or exposure that is used in the case of anxiety, for example. So those strategies already exist. We don't have a new cognitive restructuring protocol. We use those that already exist. So I want to give you an example of a boy just to illustrate how we took this approach. So John is an 11-year-old. He was diagnosed with Asperger's. He had challenging behaviors, lots of challenging behaviors. He was in general education, a bright young boy. His challenging behaviors, these were at home, and most of them occurred at home. They included noncompliance, verbal aggression, and intimidating posturing. So his mom was pretty petite, and he was pretty big, and so he'd kind of stand over her in kind of a posturing type way that was distressing to her. He didn't physically aggress towards her, but he was intimidating to her, and it made her nervous. She was a single mom. And he was diagnosed with general anxiety disorder. So he was very perfectionistic. He had excessive worries and fears and avoidant behavior. And his anxiety symptoms really impacted his functioning in addition to these challenging behaviors. So he was very fearful of making mistakes on homework. This is very common in children who have anxiety, right? Is very fearful of making mistakes on his homework. And he avoided doing his homework, even though he could do the work. He could absolutely do the work. He just avoided it, and so he had poor grades in multiple subjects because he wasn't, turning in his homework. And then he was also fearful of being late to school. And so this was very distressing to him in the morning. And so then what he would do is as soon as he got up, he would head to school. So he didn't do any of his self-care. So he wouldn't change his clothes and so forth because he was so fearful of being late for school. So these anxiety symptoms were really interfering, and then the associated challenging behaviors were really interfering with his home life. So how do we approach this with John? So I know, hopefully you can see this, but this was somewhat of an easy, straightforward functional assessment process with John. There wasn't really any confusion about what the function of his challenging behaviors were. They were really to avoid anxiety-provoking situations, such as making a mistake. So a lot of his challenging behaviors were in the context of fear of making a mistake. And the most common setting where most of the challenging behaviors occurred, and they were daily, was when his mom said, okay, it's time to do your homework. So he'd come home from school, he'd watch TV, whatever, he'd take a little break, and mom would say, it's time to do your homework, and he would go hide in the bathroom, lock the door, and stay there for up to 2 hours. and arguing with mom. Mom would argue with him through the door. I mean, this was an exhausting process, and really interfered. I mean, he essentially delayed doing his homework. So the function and setting were very straightforward. And so then what was the plan that his therapist developed with him? So the plan, we start with the child skills. So we asked Mom, well, what do you want him to do instead? Really, what's immediately, when you say, what do you want to do your homework? What do you want him to do? And she could say, I want him to start homework without argument. Okay, great. That's our goal here. And then when he was getting anxious about making a mistake, so if there was a problem on his homework that he wasn't quite sure about and he got anxious, we said, okay, short term we can have him ask for a break so that he doesn't escalate, so that we can because once he escalated, it was hours. But then longer term, we didn't want him to just be asking for a break all the time, right? He needs to do his homework. And so really the focus was on identifying and challenging his anxious thoughts, and tolerating making mistakes. So that was really the overall goal, and that was really kind of the mental health treatment goal. And so then the parent skills or strategies that we included are essentially antecedent strategies and consequence-based strategies. So Mom increased her predictability during the after-school time. She did a visual routine that he knew and he was involved in creating. What do we do after school? She gave him choices, which homework do you want to start first? None of this is rocket science, right? This is just how we organize it. She prompted for emotion regulation skills, so use your, I can't remember the term that they used for the cognitive restructuring, thinking, instead of using an anxious thought, kind of a replacement thought. There was a much better word for it that I don't remember. But she would prompt for him to do that when she noticed that he was getting anxious. And then, of course, providing praise and using a token economy for alternative skills. So that was the plan. And then how do we teach this? So we use, and I'll go through this in a minute, our active teaching strategies. And then we also applied, the therapist used cognitive behavioral therapy strategies to teach those cognitive restructuring and tolerance skills that were part of his plan. So this is just to kind of illustrate how we use this framework to address both the challenging behaviors but also the anxiety. So we're targeting both simultaneously, but we're starting with the challenging behaviors. So I want to move from kind of the treatment planning piece to what we expect AIM high sessions to look like. And so I just want to give you a little bit of kind of some of our components there. So remember how I said that therapists ask for, well, how do we adapt psychotherapy for children with autism? What do we do instead? Well, it's the same things you would do to teach, in a school setting, really, or in any other setting with a child with autism. It just is applied in this setting. So maximizing structure and predictability. The main thing we did here was use an agenda and use a written agenda. And we talked about very creative and individualized way to have a session agenda. And for folks who work in classrooms, that happens all the time. Every minute is scheduled in a classroom. But often in kind of less structured psychotherapy sessions, that's not always the case. Sometimes it can just come in with, how's your week this week? Well, that's pretty unstructured. And it doesn't really give the child an expectation of, well, what are we going to do in this session, right? So that is the first thing that we teach therapists to do. And it seems so simple. This seems so simple, but we hear the next day, Every time I give away my workshop, somebody emails me and said, I did it. And I didn't even do it with a child with autism, this child had ADHD or whatever. And it's amazing. I'll always just post a schedule. So, but again, this is not at all anything new, but this is critical. So what our typical session structure is that we always review what the child did between sessions and what the parent did between sessions. So we actually, when we're doing our fidelity for the therapists and the psychologists, we always look at, is there continuity across sessions? It's very tempting to, based on the crisis of the week, just pull out a skill out of it could be a lovely skill to teach the child and they totally need it, but we really want to stay focused on what the plan was to teach the skills. And that can be hard, right? Because you do want to be responsive to what it is. Oh, yeah, you got in this social altercation. Well, I think you need this social skill. But actually, we're working on something else. So we are always looking, is there continuity across sessions? Are you still, maybe you folks are better clinicians than I am, but it's very hard to teach a skill one time and have it work and stick. And so we want to see that continuity. Maybe it needs to be a very long session. So we always review what they did between sessions, and then we spend a lot of time teaching and practicing and repetition. We're going to practice with mom. We're going to practice with the therapist. We're going to practice with the child. Depending on who's in the room, whoever's in the room, we're going to practice the skills. And then at the end, we always summarize the session and assign between session practice. And I actually need to change the word assign. We collaboratively come up with the practice. Either the parent helps come up with, well, what are we going to do this week? Or the child does. Sometimes the child is typing it out on the computer. That's ideal. But we always, at the end of the session, actually check in with the child and the parent. Well, what did we do this session? And what skills did we work on? Because that's one more approach for repetition, and then you can correct any misperceptions that there might have been about the session. The child may have thought that the 10 minutes of Uno that they played at the end, that was the session that they learned how to play Uno. Well, actually, there was 40 minutes before that was something probably more important. So we always want to check in, like a comprehension check of what's being done, what happened in the session. And then we usually end with a motivating activity so that we want the children to have fun. We want them to be motivated, and we want them to be excited. And so sometimes getting to have special interest time at the end of the session, or to get some computer time, or whatever is appropriate for that context, we want children to want to come. So that's typically the session schedule. And then folks who are not trained in autism intervention or other related interventions often weren't necessarily taught to use visual aids in the same way that we often use with children with ASD. And so we really focus on kind of highlighting that, again, psychotherapy, when we're talking about emotions and feelings and thoughts, it's all very abstract. So anything that's abstract, we really need to make concrete. And it doesn't have to be fancy. We can just draw something on a paper towel. Visual aids don't need to be, laminated cutouts of anything. They can be stick figures. And so we try to emphasize that. And the therapists, I think it's kind of an aha moment when they start to see the kind of that power of visual aids. And then always using priming and pre-teaching, giving previews of upcoming activities. So these are basically good teaching strategies, right? Just the basics. And so, but we spend a lot of time on it because it's needed. And then we're also looking for therapists to be what they're doing to engage parents and children. And so parents often, I've coded many sessions of psychotherapy sessions from video recordings, just, in my prior work. And often I see the parents aren't there. So first of all, they're not there. Or if they're there, they're just kind of sitting and watching, right? So it's kind of a car mechanic model where we'll drop our children off, or, we'll be there, but we're not necessarily engaged. We're like, here, somebody else is gonna fix my child. And it's not necessarily driven by the parents. It's just not the expectation always that, in our mental health services or other services, that the parent is involved. Well, there's a lot of research to support the importance of parent involvement kind of across the board. So we try to really set up that expectation that parent involvement is what's expected, but that the intention is not to put strain on parents, but to really indicate that we can't do our job without a parent's input. We just can't do it. We're not good providers. We need them as a partner to be able to do our job better. And so part of how we do that is making sure to respond to parent priorities and their constraints. So, we talk about with therapists that, you can develop, we have these lovely behavior plans that have a gazillion skills on them and all sorts of antecedent-based strategies and consequence-based strategies. If it's not feasible for a family to do, then it's not a good plan. Even though it might be very sophisticated and appropriate for the child, if it doesn't fit with that family's life, then it's not gonna work, and it just doesn't, it's not a good plan. So we do that by obtaining input throughout the process. And then we also try to think about kind of a parallel process of teaching parents and teaching children, in that we really are trying, when we're teaching parents those strategies that are on the behavior plan, we're framing them in positive terms. This is what we want you to do, not what you want you not to do, right? So we're modeling for the parent the way that we want to model for the child. We also provide rationale for new skills. We link, for parents, we link the child's skills to what they think is important, and for children, we link their skills to what they think is important, right? And select skills. And then, of course, breaking things down into manageable steps for both parents and kids. And then for the motivational strategies for children, this is, I think, that probably the most powerful motivational strategies that I've seen our therapists do is really incorporate the child's preferred interests and special interests. Because I think when we heard in our needs assessment that therapists felt like, well, I don't know how to manage these special interests. So some therapists were letting a child talk about their special interests all session, and some were saying, nope, you can't do, you can never talk about your special interests. And so we try to use that strategically. So if there's a way that an interest in superheroes and comics can be used to illustrate some concept that's trying to be taught, then that's how we use it. It increases attention and retention and so forth. So really that is, and I think that's new to folks who weren't trained or don't specialize in autism interventions. And then, of course, finding different ways to share materials and share control with the child. So does the child, can we, we always, problem solve with the therapist. Well, how can we give this child control? How can we share the control in the session? Are they in charge of writing the schedule? Are they in charge of determining how we're gonna do the role plays and so forth? So we just try to be creative in that it's not all adult driven. So those are just some of the strategies that we include. Active teaching should also be something that is not new. We just use the term, we usually say active teaching sequence. But what we mean by this, and this is to teach both child and parent skills. This is very well researched in the adult learning literature as well as the child educational literature, is that when we're teaching either children or adult skills, first thing we do is describe what it is. Briefly is key. What we see is that often there is a lot of time spent explaining and giving rationale for 20 minutes, just explaining it, and then we expect that a child or a parent's just gonna go and do it with us explaining it. It's really setting up a family for failure. So we try to yes, it's important to describe a skill, but keep it brief. Modeling, this is something that typically happens, is that there's some modeling of either, a therapist modeling for a parent how to give an effective command, for example, or modeling for a child following directions right away, right? So that's modeling. And then the next two, though, are the most important, and the literature supports this, both with adult and child learning, is that where learning happens is when there's opportunity to practice and receive feedback. And so I'm guilty of this. I am certainly guilty of this, you have a session, and there was this crisis, and we talked about all of that. Then I describe, what we'd like to happen. Oops, there's no time to practice it. And that's it's again not setting up for the best success for a family. So we work with therapists on how do we self-manage our own sessions to be able to make sure that practice and giving feedback happens every session. That's what we give feedback to people on the most. And that the feedback is immediate, and that you don't just do one role play of a skill, because that's not how we learn. We have to do it lots of different places. And can we go outside of the office and go, down to the deli and practice that skill, or, where can we practice that? And then identifying additional practice opportunities during the week and so forth. And we really need that for the parents to be involved in that. Even if it's actually a behavior that we want to see at school, the parents are our partners here, because they can help that child practice something outside of school at home that then they are more likely to use faster in the classroom. So that's something that is kind of an important rationale, even when we're talking about behaviors that occur in the classroom. So, kind of back to the research piece. I hope that just kind of gives you a picture of what Aim High is and what we spend 6 months teaching people to do. It's really about how are we going to use these strategies that are in themselves very, very simple, but how are we going to use these for a specific child and their family and the context that they live in. So hopefully that just gives you a preview of what Aim High looks like. So as I mentioned before, we did a pilot study just first before, just to test out our materials. Is it useful? Do people like it? Are people going to use it? Are therapists going to use it? Do the parents like it? And so we did that, and we found that therapists really liked the structure of Aim High, and parents really liked the structure of Aim High. Actually, we got feedback from parents and therapists, and they both said the same things. I mean, literally, some of their feedback was exactly the same words. It was that they liked the structure and that they liked the explicit focus on collaboration and involvement with the parents. That's what therapists liked, and that's what parents liked, or those two aspects. And they felt that it was acceptable and in their setting, so in a mental health setting, and that we saw reductions in challenging behaviors after therapists delivered Aim High. So what we are wrapping up right now, as we speak, is a large-scale effectiveness study of Aim High. And so this is a randomized trial of Aim High in San Diego and LA counties, where we, of course, after our pilot study, we revised and revised. We didn't revise any concepts, but we just revised terms and made things prettier and just more user-friendly. That's really all of our revisions, not concepts. And so then we just finished training our last cohort of therapists in this trial. So I just want to talk a little bit about the Aim High research that's just wrapping up, and then where we're going with this, and then hopefully leave time for questions. So what the Aim High effectiveness implementation trial is, like I said, it's a randomized control trial. Typically, when we think about randomized trials, we think about randomizing children to, maybe if it's some drug treatment, to either the intervention of interest, the treatment of interest, or a placebo or waitlist control or something. We actually randomize programs. So we randomize either a mental health program, like a community program, or a district if they're doing their own educationally mental health services. So we randomize at the program level of whether they were going to get immediate AIM-High training or if they were going to do routine care first and then get AIM-High training. And then within those districts and programs, then we recruited children to participate. So we're first interested in the impact of AIM-High on child and family outcomes. So we want to know, do challenging behaviors, do they reduce? And we're looking at that over 18 months. So AIM-High generally takes about 6 months. Sometimes the kids are still in treatment, sometimes not. But then we're looking at the long-term outcomes up to 18 months. So we're still collecting the follow-up data on that. Then we're also looking at who responds best to AIM-High. So what are the child characteristics that, anywhere from cognitive functioning to ASD severity to other symptoms, other psychiatric symptom severity, how do they influence the outcomes of AIM-High? And they're also looking at, does therapist fidelity, so how well therapists use AIM-High, does that impact outcomes? Then our next aim is to look at what's the process of implementing AIM-High? I mean, this is kind of a big scale up. I'll show you our numbers in a minute. What can we learn about implementing new practices that, we have this advantage of using these in big systems. What do we learn about implementation process that could be applied to other settings or to other interventions? And then we got some additional money to a disparity supplement. We have one of the highest, if not the highest, proportion of ethnic minority participants in an autism study. So we were able to obtain additional funding to look at, how does AIM-High treatment process work by family ethnicity? And are there differences? And are there adaptations that are needed? How do we best meet the needs of all of the families that will be served by mental health? So these are our as of a few months ago, these are our final numbers for this study. So we had 29 programs, mental health programs, participate in LA and San Diego County, and those are with either mental health programs or clinics, like outpatient clinics, or school districts. So either of those, or I should say, and school districts that were in LA and San Diego County. And then within those programs, we have 172 therapists that participated. Not all of them received AIM-High training. Some of them were in our kind of observation condition where we were just collecting outcomes on the kids who didn't get AIM-High training, or their therapists didn't get AIM-High training. Not surprisingly, our therapists are mostly female, about a third Hispanic and about a third bilingual. I would say more of our bilingual therapists were in San Diego than in LA County, roughly. And then from those therapist caseloads, we had 202 children receiving these therapists. So 80%, 82% male, which is what we would expect in an autism study, about 56% Hispanic, and their average age was about 9 years old. And those were children, so we don't directly recruit therapists, and we don't directly recruit kids to be in our study. So we start with the programs, we enroll the programs, then we recruit dyads, really, of therapists and their clients or the student with whom they're working in to participate in the study. So those are our final numbers of participants. I'll spend just a few minutes talking about just some very preliminary findings related to training outcomes. So our child outcomes are still being collected. We're collecting those for another 9 months or so. So I'd like to be able to share those with you, but I can't. But what I can say is that what we're finding is that we are impacting practice, because we can compare, we're collecting videos from our therapists that are participating in kind of an observational condition versus those who are getting AIM high training. And so we're looking at how their practice differs. And we are finding significant impact on therapist practice. So this is just an example of, this is really based on our kind of within session fidelity, which, remember I went through all those within session elements that were about structuring the session, using active teaching strategies. So we have observers who are blind to the condition of a video, right? So the observer doesn't know, is this child and therapist, are they in AIM high or not? And then they rate the extent to which a therapist uses any of those strategies that we were teaching them. The light blue bar are the therapists, this is their behavior or their practice, who have not received AIM high training. And then the dark, I don't know if this is blue or purple, but the darker bar on the right are those that have participated in AIM, or are participating in AIM high training. So these videos are collected during the 6 months that therapists are delivering AIM high to a client or a student, and are participating in the consultations. And so what you see is that in all cases, this is statistically significant that we see much higher intensity of these strategies that are being used when we train folks in AIM high. And this is again, these are strategies that work with many kids and families, but are essential for kids with autism. Our effectiveness ratings are really about not just how extensively do we see something, but are the goals of the sessions met? So we have really 4 effectiveness ratings that are, does there seem to be continuity across sessions? So that's one of them. Is there really clearly explicit skill building? Does it seem that everybody knows what's the child's skill or what the parent skill is? So can a blind observer assess, oh yeah, this is what we're teaching here? Because if it's clear to somebody else, then it's more clear to the people who are participating. And then we also want to see how well they're engaging folks. So this is the effectiveness ratings are really how well these strategies are being used. What I would say about this is we're making a really significant impact on practice. Would I like to see these ratings higher? Yes, I would like to see them higher. So that's our next step, is because we saw that there's actually a lot of variability. I'd like to see folks up to kind of in the 4 range is really what I would say is ideal. So there's a lot of variability here. So we're making a big impact on practice, but I think we can even do better with with our therapist training, I should say. So we started to look at, we have about 75%, 76% of therapists who receive AIM high training are successful in the AIM high training. So they complete the consultation series, they meet fidelity, they get certified in AIM high. And I think you can look at that both positively and negatively. That's a lot of people we're impacting here. And that is a high rate, we're effective. I want to see if we can get that number higher. And even within those who are successful, there's still variability in their use of AIM high. So we're really thinking about, okay, how can we make this better? So we started to look at, okay, well, what factors help us see who's responding best to AIM high training? Who, meaning at the provider level, not child level, the provider level. And what we found is that both therapist factors and organizational factors seem to impact the success of therapists' participation in the training. And what we found was therapists' attitudes towards evidence-based practice prior to training was a positive predictor of successful outcomes. So those folks who are more open or they see more appeal to learning a new practice, they were the folks who stuck with us, that continued through the 6 months of consultation, who met fidelity, and so forth. So that's important. The attitudes are important. And that was something that's hypothesized, but it's not necessarily been documented in this context. And then we also found that organizational factors were important. So therapists' perceptions of the climate in their organization, so the organization either being kind of an outpatient clinic or a school district, their perceptions of kind of the support for implementing something new, or the support that they received in learning a new practice, that for the therapists that had more positive perceptions of that they had more positive training outcomes. And then those folks also were from programs where their leaders used more implementation support strategies. So the leaders were more involved in the training, in helping. So one of the things that was required to participate in the AIM-HIGH training is that you had to have a student or a client with whom you could use AIM-HIGH training. And so some leaders were really, really active in saying, okay, you want to participate? We're going to find you a student. We're going to find you a client. We're going to, and so they were really active in matching, so that, and then in supporting that therapist and finding. So that's just one example. But some of the leaders participated in the training with us. Some of them went to a few, not all, but some of the consultation meetings or checked in. And so they were just using more strategies to support the therapists or the psychologists. So really what we were thinking here is, okay, our next step is how do we really enhance this training? And so we're really thinking about what can we do to help the therapists kind of come into AIM-HIGH with more positive attitudes, and what can we do to help leaders to support the therapists as they're learning it? So our next step is we're keeping our fingers crossed for funding. Soon, I think that it's looking very positive. But our next study is really about pairing AIM-HIGH training with implementation strategies to see, can we get the percentage of folks that we train? I mean, we invest a lot, right? Can we get that number higher? And even those that are very successful, can we help them sustain their new skills longer? Will they use it with other children, not just that child with whom they're learning AIM-HIGH with? So how do we get the best outcomes here for provider training? And so our approach, and this is in collaboration with Aubin Stamer here at the Mind Institute. She has been doing teacher training and classroom pivotal response training, and actually we have very similar outcomes for provider training. So we said, all right, well, let's collaborate here and see if we can test some implementation interventions together and see if this is helpful for both of us. So what we've decided to do is to develop kind of a module that addresses kind of a motivational enhancement module, so that prior to and during AIM-HIGH training, we're really explicitly focusing on what's the therapist motivation, what's motivating them to be here, and how else can we help them be motivated to be there, so that because it's hard to learn something new, and to have people watching what you're doing, you have to have some level of motivation to continue that. And so we're actually borrowing from the concepts of motivational interviewing to enhance our training in that way. And then we are also planning, hopefully we'll get funded to do this, on a leadership training that will involve, prior to doing any training with providers, working with either district leaders or with clinic leaders or agency leaders, community-based agency leaders on, how can we support our providers in learning and delivering new evidence-based practices. So we're really excited about this next direction, and if we're funded, I would expect maybe 2 2017, 2018, to really be starting this, these trainings again. We propose to do this in San Diego, LA, and in Sacramento. And so, oh, and Patty is holding up a clipboard. So if you're interested in AIM High training, I'm happy to keep your, to keep your contact information. And if we're funded, happy to follow up with you if that's something that you're interested in. So we'll be looking at how do we enhance training in these 3 counties, large and diverse county.
Hi, my name is Kat, and I'm kind of here with a dual purpose. I'm a program trainer with an adult family home agency, and so I train care providers in the community how to support individuals with spectrum disorders and many other disabilities. But in addition, I have a 7-year-old superhero at home with autism. So we've been working with an ABA therapeutic team for 2.5 years, and recently one of the things that they've kind of brought to our attention is a study that came out indicating center-based service versus home-based services. And I'm wondering if you guys have identified how AIM High or any of the other programs are impacted by where those services are being provided. The study that they gave us indicated that there was this extreme buildup of services and skill sets that happen within the center-based services. So if I drop my son off at your center and you do center-based services there, he's going to be 80% smarter than if we do it at your home, is pretty much what they gave us information on. Our concern and what we started noticing when we started doing that is that they were mastering skills for him in the center that he wasn't generalizing in the home environment. And so I'm wondering if you're seeing the same type of thing, because they're kind of making us feel badly about asking them to do it in our home. And I said, but this is where he lives and this is where he exists. This is his world. He doesn't exist in a small room with a locked door with nobody else and no distractions. His brother's not there, the TV's not on, And so I'm wondering if you could provide any feedback on that, because that's kind of where we're stuck right now with that particular vendor.
Yes, so I'm not exactly familiar with that study, but I know that there's been discussions about, whether clinic versus home-based services. I think that what's most important, and I didn't talk about this here, but we talk about it a lot in AIM High training, because this is something that's new to folks who don't know autism, is the challenges with generalization, right? And so generalizing skills from, using them with one person to another, or in different settings, from one settings. And that's actually why we put such a heavy emphasis on our between session practice, is because, well, first of all, an hour a week, which is often what folks are getting in outpatient and maybe even less in school-based mental health services, is that's not intense enough to necessarily develop the skills. So that's why, outside practice is really, really important. And we know that that's the case with children with autism, is that the generalization is really, really challenging. So I think there's a number of different ways to work on generalization, but it needs to include practicing skills in multiple environment with multiple people. That's really important. And so it's really critical that happens in some way. Now, does that mean that services need to be delivered here versus somewhere else? I don't know that we have the data on that, because you can do naturalistic interventions in clinic-based settings if they're naturalistic, right? And so we have some programs, there are some mental health programs that kind of do a blend of outpatient clinic and home, or a blend of outpatient clinic and school. It kind of depends on where the money's coming from, of how that happens. We will be able to look at that. I'm not sure that we'll be able to attribute differences to the setting for that child, or is it differences in the structure of the organization? I think it might be challenging to tease those out. We'll try to do that. We have less that, I don't think we have any programs that deliver just home-based services. But I would say if you're having concerns about the generalization of the skills, then I would go with those concerns, your child, and clearly raise those concerns about, how are we going to work, regardless of where they're initially taught, how are we going to work on this? Another question, yes.
Thank you so much. Your presentation was really great information. I wanted to know that if you are working with any of the school districts.
So when we started the current grant, it was 2012. We started July of 2012, and that's right. Do you remember when AB 2726 went away? That was the day we started this, this grant. So when we originally wrote the grant, we were really more focused on kind of those community-based agencies that were either providing Medi-Cal-funded mental health services or those services through the school districts, right? So then there was some transition time for those services. And the bottom line is yes, we are working with school districts. It's been a bit challenging because we came in during a transition, and in San Diego, at least we have a number of different school districts, and they're all there may be more closely, they're closer now into what they're doing, but at that time when we started, it was the year, the day after this started, and the programs really weren't even developed as programs yet for some districts. They were just developing their ERMS program. Some of them were still contracted with the same agencies. So we have, and what I would say is, I wasn't expecting school psychologists, they weren't typically the ones who are training, who are delivering mental health services, but we have school psychologists in the study. We have MFTs and social workers who are employed by districts, or they're employed by agencies that the districts is contracting with. I'm trying to think if there's another setup. That's probably it, really. But they're all different. The districts are all doing things differently, and so we do have districts participating. Yeah.
Thank you very much for your presentation. My name is Rumi, and I'm a mental health clinician providing mental health services in a school district. I'm wondering if you run into any challenges of maintaining parent engagement or parent participation.
I think it's a great question. So are we running into challenges maintaining parent participation? I think that the challenge is actually at the initial part. It's not about the maintenance, because once the beginning part of Aim High is very structured, and it completely relies on parents. You really can't do the first part without the parents. And so to get started, the therapist really needs to be in contact with the parents. And so I think that what's nice about the structure is then it just becomes a routine part of the counseling or the therapy that parent is somehow involved. And we check in with the therapist, are you involving the parents? So I think initially is where we have more of a challenge, but that once they're involved, we haven't seen as much of a challenge. It's really kind of problem solving. Well, in this district, we do this related to parent involvement. There's a lot of variability about that. And so what's feasible given the role of the person providing the mental health services, and then what's feasible for that family, because these are happening during the school day, which is often during the work day. And so that's really where the problem solving comes in. And then once that's kind of taken care of, that's where most of the challenge is. And then once we figure it out, then it continues.
Do you want to tell them real quick about your sign-up list in the back?
Oh, yes, I think I mentioned that. So Patty's holding up a sign-up list, just in case you are interested hoping that we're funded in possibly getting more information about Aim High training, please feel free to leave me your email address, and we will keep you up to date.
Just really quickly in response to that, as a parent with a child with autism, one of the things, I do community trainings as well for parents, and I work with clinicians a lot. And I remember when my son was diagnosed, and I had been working in the field for 15 years at that point and thought I was prepared for pretty much anything. I remember that example that you showed up there where you were talking about the purpose behind a behavior, and that one kid that you worked with that said he didn't do his homework because there was a fear of the failure of the making of mistakes. I think that when you guys are working with parents with newly diagnosed kids, you're working with that kid. Suddenly, they have an undiagnosed anxiety disorder that nobody's identified or treating them for. And as a parent, I remember thinking, wow, I thought I knew things, and now I know nothing. And that fear of making a mistake across the board, I think, creates that design for parents to step back and say, I'm the layman and you're the specialist, so you do this. Because there's that fear on our part that we're going to screw up anything that you do. So just my personal feedback on that and what I've heard from a lot of parents, just be patient with them and treat them with an anxiety disorder approach, perhaps, at the beginning. So that's my thought.
I think there's a lot to that. I appreciate those comments. To engaging parents, and that's what it involves. Not just asking parents to change their behavior, but understanding what are their needs and what really is feasible. Because otherwise, we get frustrated and aren't really paying attention to what's really going on. And so we do, in our consultations, we spend a lot of time on, okay, this is, how are we going to engage this family? What do they need? What cultural factors are playing into here about, even asking questions? We try to encourage asking questions, but sometimes that can be intimidating. And so we really have to tailor to that family.
When you were talking about caregivers can include the teachers, how is there a training component so that your mental health provider learns how to train the teachers who have the child or who's demonstrating those behaviors that are challenging for 3 to 6 hours per day so that they can implement the skills that they're trying to learn in the clinic and or the therapy room at school?
So that's a great question. So we don't have a teacher. We did not intend. This was intended to be a parent-mediated intervention. And so we spend a lot of time on how do we engage parents and how do we teach parents, and using adult learning. And it's really the school folks who've initiated with us when they said, well, this is helpful information because not only can I work with parents using these strategies, the modeling and the role play and the practice and so forth, and even just the behavior tracking, the tools and so forth. But can I use the same strategies that I would to teach a parent? Can I use that to teach a teacher or an aide? And we said, sure. It's adult learning. So we don't have a specific component. It was not intended to be that. But the folks who we've trained that are working in the schools, they've initiated that. So I think that a number of the school psychologists or even the social workers who've said, oh, I'm going to start doing this with the aides and the therapists. So they've initiated it. It's not a separate component, but what we tried to do is we've just tried to communicate that this was intended for parents, but it really is caregivers. And if teachers spend a lot of time, if you want to use it with teachers, great. There's not really anything different necessarily that I would say. So we encourage people to do that, but not at the exclusion of parents, right? So not instead of parents. That's really important. So I think we need to wrap up. Thank you all for coming.
Thanks,
I appreciate you staying here late in the afternoon.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.